All right, so welcome everyone to this month's Teach Educational Rounds, our panel discussion on smoking cessation, a pivot to virtual care. Our panel discussion today will be moderated by Dr. Peter Selby, and we will have our three panelists that I'll introduce momentarily. We will just be beginning with our land acknowledgement. So CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So I will now invite everyone actually to, in the chat, let us know which traditional territory you are joining us from today. And if you're not sure, you can visit the link that we have there, so www.whos.land to find out. And you're also welcome to let us know one thing that you're doing to learn or improve your commitment to reconciliation. So we'll give you a few moments to do that and share in the chat, and then we'll continue on. Wonderful, thank you for sharing. Give everyone else some more time to share. Wonderful, thank you. Wonderful. All right, well, for now, I'm going to keep going, but feel free to keep sharing in the chat. I'm just going to go through a few housekeeping slides. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for the webinar, completed the pre-learning assessment. Please make sure you've also signed into the webinar using your full first name and last name so that we can track your participation. And lastly, please make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow. And along with that, I will also be sending the presentation slides as well as the recording. So with that, I'm going to now give you a little bit more information on our moderator today. So Peter Selby is a senior medical consultant and a clinician scientist at CAMH. He is the interim vice chair of research, Giblin professor, and director of addictions and mental health division for the Department of Family and Community Medicine, and full professor in the departments of psychiatry in the Dalla Lana School of Public Health at the University of Toronto. His research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. He also uses technology to combine clinical medicine and public health methods to scale up and test health interventions. His cohort of more than 300,000 treated smokers in Ontario is an example of this work. So here are his disclosures, so I'll give you a moment to read through those. And now I'm going to introduce our three panelists for today. So first up, we have Darrelle Carpentier, who is a research assistant for the STOP program. Darrelle has been with the Nicotine Dependence Service at CAMH since 2018. She has been working with clients in a research capacity through both the NDS clinic and through a new virtual program called Stop on the Net. So welcome, Darrelle. We also have Huma, who is a social worker at the Nicotine Dependence Clinic at CAMH. She works closely with the clinical team at the NDC to provide individual as well as group support to clients who are interested in making changes to their nicotine use. So welcome, Huma. And last but not least, we have Colleen Levelton, who has had a long association with the Nicotine Dependence Clinic at CAMH. She even credits the supportive staff for having been able to have her artwork displayed 3 times and then being seen exhibitions at CAMH. Today, we have the honor of having her here to provide a client perspective in the pivot to virtual care. So welcome, Colleen. And no disclosures for our panelists. So please note that the content of Teach Educational Rounds is primarily centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat feature throughout the webinar to post any comments or questions and to answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel if you haven't already been able to figure that out. And today we also have the ability to send reactions. So if you would like to do that, you can find the smiley face icon in the control panel and select the reaction you want to send. So with that, I'm going to hand it off to Dr. Peter Selby to moderate our discussion. Thank you, everyone, and enjoy the webinar.
Thank you very much, Natalie, and welcome, everybody. A warm welcome to everybody from across the land and the territories and treaties that accompany those. And thank you for sharing those as well as we increase our work towards reconciliation. Our group at CAMH in the Smoking Cessation Clinic and the NDS are very committed to this work and have been doing work with our Indigenous communities and with Indigenous communities and in collaboration with them across many jurisdictions. And we look forward to continue to deepen that relationship and work towards reconciliation. So we really wanted to talk about describing adaptations to the treatment during the pandemic. What are the considerations when we are trying to do this online work and using technology? And it's, often we have to think about everybody along this way, and it's especially running online groups. And then how do we figure out, and how did we figure out with the lockdowns and other restrictions, how can we use technology and other essential services to make sure that people who are otherwise used to coming into a clinic to be able to access services. So we're going to keep this as a panel, and I think if we for now just stop sharing, and so you can see the panelists in your screen, then we can have this conversation, and I'll just go around asking questions of our panelists. So, we are part of the pandemic, and this is well known, where people are getting kind of pandemic fatigue, and everybody is kind of struggling, and we're seeing this play out in society. So it's not an unexpected reaction of what we are seeing and what's happening with people. Especially with waves, and just like in the flu pandemic, the final wave was the worst in terms of how people responded to it. So, history is repeating itself. But what is different is we have technology, and technology is a double-edged sword. It can be used for good or for bad, and for in many cases, it depends on where you stand. Technology can be really harmful. But on the other hand, what we want to talk about is what is the responsible use of technology and the ways we engage people to continue with their journey. As we know, if you just step back in Canada, not so in the US, but in Canada, the number of people in the last 2 years who've died from COVID is still about half as many as those who die every year from smoking, right? Smoking in Canada is about 51,000 people every year. And that's annually. And that didn't stop because COVID hit us. In fact, it continued. So it's not to say that COVID isn't important and an important piece that we pay attention to, but we also need to pay attention to this endemic issue of tobacco and tobacco use disorder, and that there were people who were still interested in showing up. So what I think is, because we are here in the service of people who smoke and who have issues with it, I think what I'd really like to do is, if that's okay with you, is Colleen, ask you in terms of relating the last couple of years to your smoking and your work with the clinic and how that has adapted and evolved compared to previous times. And maybe you want to let people know a little bit about yourself as much as you're comfortable, and then.
Yeah. Well, I've been with the clinic for a really long time, and I've been really grateful for how they always welcome me back and even call me when I haven't been there for a while. And I've been really appreciative of the online support groups during this pandemic. The availability of them is fantastic, and you know, it still provides the accessibility to staff help and group support, and there's still social interaction, especially if somebody has a sense of humor in the group. I really appreciate that, you know, and the location is your own home, and so there's no TTC fare or travel time. And I would say I'm, you know, at first I missed, you know, the kind of personal, it's more personal to meet with people, I think. But I've gotten used to it, and I appreciate it now. And I'm going to continue with it.
Thank you.
The online.
Thank you, Colleen. So that's great. So maybe this is a good segue actually to Huma to talk a little bit about how the group went from, you know, in person to online, and what was some of the, as a therapist. So if you don't mind introducing yourself a little bit about your work, and then talk about this transition and how you went about it.
Yeah, absolutely. So I'm Huma. I'm one of the social workers in the clinic, and I work with about 4 other therapists, and we all kind of collectively provide group support and individual support to our clients. So pre-pandemic, the way our clinic functioned is, of course, like most outpatient clinics, we'd have people come in, they'd be physically present for our groups, we'd be in one room together, and we'd have our groups during the scheduled times, which was usually 9 to 5, Monday to Friday. So the benefit of switching things over to virtual, which we did about the summer of 2020, we had a bit of a delay as we kind of figured out the switch. But once we did that, things changed quite a bit in how we ran groups, when we offered groups, and how many groups we offered as well. We were actually able to increase the number of groups we offered just because our schedules kind of allowed for that flexibility, and the demand for our services also increased because, like Colleen said, the barrier of people actually having to travel to our clinic to attend a 90-minute group session was now removed. So instead of having to take like half a day off work or a full day off work, people could just kind of flex their time at work, or, you know, we even added evening groups so they could come in the evening. So it made things a little bit more accessible for our clients. For us, in terms of admin work to run the groups virtually was a little bit different and a bit of an adjustment, because before we kind of had a running list. People signed up, they showed up when they wanted to. It was kind of an open model for people to attend groups. And once we started doing things virtually through Webex, if you have any experience using any virtual platform through video conferencing, it's a bit more technical. So we actually had to close our groups, meaning every week we kind of knew exactly who was supposed to attend, send those emails to those people, and manage the lists that way. So our groups became a bit more closed. But as a result, like I said, we were able to offer more groups because we realized if it's closed and we can only offer it to 10 people at a time, we need to add more sessions. So we're finding attendance is increasing for our groups, interest for our groups is increasing, and engagement too. I think we have really fantastic engagement in groups because, again, people can attend when they need to, so they don't kind of have other things of like, is it snowing? Is it raining? Is my commute going to be horrible? All of things.
Thank you, Huma. And so, please, as we are going along this, we want to start seeing questions or comments that please, type them into the chat. We are open to starting this idea. So what I'm hearing is the advantage is that there was a trade-off, right? You traded off, Colleen said she trading off the in-person touching base, but the convenience of being able to come in was important. And similarly, we could offer more, but the technical issues were a challenge because you had to keep it closed and having to prepare that much longer before. And then, but on the other hand, you saw people more engaged at one level. So paradoxically, it had a different effect. Any other topics that, based on your online groups compared to your in-person groups, did the topics change? Did the content of what was happening change? Or what did you notice there?
Yeah, I don't, I mean, in terms of the groups we offered, so we have two different kind of main groups that are kind of constantly running. So the first one is a skills group that's about 6 weeks long, and it's psychoeducational. So we have set topics every week for 6 weeks. And like I said before, it was kind of open. So you could jump in at session 3, kind of attend the whole 6 weeks, or only attend the sessions you really wanted to. And now that it's virtual, we kind of start with everyone at session 1, and everyone kind of goes through to session 6. So that was kind of our main group. We've kept that the same, but like I said, we've just kind of closed it. So we have the same people finishing that started. The other group is a more ongoing support group. So it's bi-weekly, which is a bit of a change for us because we used to do the group weekly as well. And with the increased interest, in order to get more people to be able to participate, we actually switched that one to bi-weekly. We still run it weekly, clients attend bi-weekly. So we have 2 cohorts for each week. And that one is, clients bring their own topics. So we throw it out to the group, what would be most helpful for us to discuss today. Of course, sometimes the pandemic comes up, people coping with the pandemic, people coping with how do I avoid smoking when I'm constantly in my home and I can't leave my home and I smoke inside my home. So all of those things have kind of come up, but those 2 groups have stayed the same. One thing that I will say has changed is we used to offer a lot of other kind of one-off groups. Mood management being one. We were in the process of preparing a sleep hygiene group. So those things have been put on hold until we can kind of figure out ways to offer them that we can fit them into our schedules. But otherwise, those core 2 things have been the same.
So I'm looking at the questions that have come in, and one of the issues is a great question that we worry about is how do we include people without technology or low minutes on the phone or no internet? So, who would like to take that one? So Huma, maybe you can start with it, and then Darrelle, I saw you nodding, so maybe you could talk to that as well.
Yeah, absolutely. That has been a challenge, I will say. For people who don't have the internet, we do have the ability to call people into groups, and we have done that. Of course, the downside of that is they can't really see anyone in the group, and we can't see them. So they're just literally on the phone with us, but we have done that. If they don't have access to a phone or internet, it becomes a little difficult for us at the moment. But we do have physicians who are on site, so they're not completely like cut off from our services. They can still access services. And if we can figure out a way to get them on the phone with us, whether it's, using a friend's phone or going to the library to access the internet, whatever it might be, we're still kind of working a bit on that. But we're trying to provide services to anyone who needs them. We don't want access to technology to be a barrier, but of course, in a time when we're using technology as the basis of when we provide services, it inevitably comes up as an issue.
Yeah, and I'll just add to that as the physician. So one is, yes, if there's people who are in precarious housing or don't have access, clearly we've used the phone a lot. In fact, most of my appointments actually have been more by phone than by video conferencing. There are very few people who are coming to our clinic. The advantage is I see people from all over the province now, whereas they, would not be able to come in individually for an appointment. And we are seeing people who have cancer and other things, so they really appreciate that sort of ability to be seen. And then we virtualized the sending out of nicotine replacement to them, or even their prescription. I can fax it to their pharmacist. So that kind of complements this idea. And yeah, we are worried about this. One of the things we did was also try to help out with some of the shelters, etc. And earlier on, especially the COVID shelters, we sent out nicotine replacement to them to be able to just distribute to their, so that didn't, we were able to get a donation, we were able to do that. And now I'm very interested in looking at how we can do, with different settings, do similar kinds of things, because not in congregate settings where people can't move. So how do you help support them as well? So yeah, that's a great question about that. And I think before we leave this point, as Madeline White has asked, how do you account for confidentiality? For example, if they're living with others, how do we ensure privacy, especially in the group? So maybe you can talk about that consent and how we do that.
Yeah, absolutely. That's actually another piece that we've had to add into getting people registered for our groups, is we actually have a pre-group call with the client to go over all of this stuff. So confidentiality, requesting that they're in a private space, obviously making sure that, when they have their camera on, that there's nothing visible that might be triggering to others. So all of this we go through with them before they ever join a group. But every session that we have, we leave a 15-minute buffer. So during that 15-minute buffer, we get clients to log in and we check them in individually. So if I'm running the group, it'll be me, my co-facilitator, we'll check in the client. And we ask them 4 questions every time. We ask them if they're in a private space. We make sure that they are. We ask them if they can stay for the whole session. Because if they suddenly drop off the call, we need to follow up with them to make sure everything's okay. But if they tell us, I have a phone call, I need to leave, we don't have to worry about that. We ask them about their mood as well as a safety check. And then we make sure that they're not recording the call. Those are all things that we check in with them every single time they join a group. So the participants who've been with us for a while, they just they know the questions off by heart after a little while.
Yeah. So Darrelle, maybe you can talk about the other next step in progress to this. Yeah,
I was just going to say, paralleling Huma's experience. For me, for us, it's the study, it's the STOP study. And running the study virtually was something that had never been done on our end before. It's something that we kind of always dreamed of. And then the pandemic sort of not forced our hand, but helped us along is probably the better way to say it. So exactly as Huma had mentioned, we did everything in person. People came in, they met with our clinicians, they met with the doctors, they met with the study personnel, and all of that was done in person. And now we've managed to move to an entirely virtual model where all of that is done by phone or by video conference. And I think these topics have already kind of been covered. There's just more of a freedom and an accessibility for clients that they found because they can do this from the comfort of their own home. There are, of course, some limitations in terms of technology and access to technology and even familiarity with technology. We do have some people who just are simply not that comfortable with doing things online, doing things on the internet. So again, the good old telephone saves our bacon again. And we end up being able to use it as a tool to make sure that our programs are still accessible. And that's been pretty important. Yeah, I think.
Thanks. And again, this is a journey. We are testing it out. We did a mail-out version of nicotine replacement way back in 2005, and all the way from doing it as a part of the first iteration of STOP, and then we did a second iteration like that. Then a colleague of ours, John Cunningham, got a grant from CIHR and actually did a randomized trial and found that it worked even then. And then the impacts of bailing out nicotine replacement continue to continue to benefit people. So very interestingly, despite the evidence, when we would present to government back then, no one would they would not listen to us as that this should be an enduring part of the Ontario response. Of course, we had to have a pandemic where suddenly it forced the hand. And the good thing is we were ready, right? And similarly, we were ready with this. So it was very easy and very quick for us to launch this, internet-based program, because we've done it before. We've done it by phone. We've done it by, internet. And in fact, just today, a colleague, in 2005, we did a pilot where people could even get the prescription medication on the internet. And we just today have published a study done by Dr. Laurie Zavatello and a student as well, who's also part of our team, on how people can access a self-assessment and then get bupropion or varenicline through a prescription through their primary care provider, and have it mailed out to them. So, we have done that work of how this can be done, and so that's obviously some things that we're always looking at. Is what our belief is that when adversity falls your way, we've got to be creative and try to figure that out. And I'm sure many of you have done that, and so please feel free to type into the chat how you've adapted and what you've done with this. So and that's certainly one thing to think about. And Caroline, coming back to your comment in the chat about, technology is not a panacea for everybody. It's not, and I think what we have to start doing is looking at segmenting for which person, for under what conditions does in-person make sense, hybrid make sense, and completely virtual make sense. So who can do which piece? And I think if we do that segmentation, what will happen is we will have hopefully more resources to devote towards the people who need more time from experts or who need face-to-face time, because a lot of the other pieces have been automated. And that's been the goal of STOP all along, is to figure out that. So stay tuned. Before we go any further, I want to get Colleen's thoughts about what you heard about the groups, what you've heard about Stop on the Net, and other things that we should be doing, or what you would want practitioners across Ontario and elsewhere in Canada to know about programming. Oh, so I think, Colleen, we have you on mute, unfortunately.
There. How I first heard of CAMH, smoking cessation, is that what you would like to know?
Well, and what you'd like people to know about, programs that during the pandemic or virtual programs that they should keep in mind from your perspective.
I have really enjoyed the online smoking support groups, and that's the one that I've been using during the pandemic. But I also I benefited from an online art course from one of the Workman theater artists, and that was great. And my wish list would be to see the online continue for both support groups and the arts and crafts area.
Yeah, and I'm not sure everybody knows that, because within our group, one of our therapists would have this idea that people wanted to do something with their hands. So when it was in person, there was this arts and craft group that happened, and it's very interesting that it's been. Colleen has experienced it virtually. I don't think we've done it, but it's Workman's Art is affiliated with this, is an organization in Toronto that does this. So I think that is the other things that we've noticed, is that we can connect to a way more other virtual things, whether it's Wellness Together Canada or whatever. All of these things have suddenly become available, from that perspective. Okay, thanks for that. And coming back actually just to the question in the chat, Chantel asks, if you have to step back and take a look at no-shows, how have they gone in person versus online?
I would say, sorry.
I was going to say, from a study perspective, yeah, we've definitely noticed a drop in no-shows. So people who want to enroll in a study, it's because it's so much more convenient for them to be able to do it from their home and not have to come in and show up. And even just being able to reschedule as well. It's easier to reschedule. So we definitely had a drop in the no-shows. That's been good.
Yeah, sorry, Huma, go ahead.
Yeah, I would say the same. We've had a drop in no-shows, again, because I think it's convenient for people to speak on the phone with us. Most of our assessments as clinicians, we do them over the phone with clients. And even if they forget, oftentimes we'll call them and say, you have an assessment scheduled for now, and they'll say, oh yeah, no, it's fine, let's do it. So whereas before, you know, if a client forgot and they were supposed to come into our clinic, that was time that we would lose. Now we can kind of catch the client, even if it's 15, 20 minutes later than originally planned, we can still get in touch with them. So I think the no-show rates have definitely dropped.
And I would concur with that. Even in my clinic, who I'm scheduled with, maybe I'll have an 80% show rate for the online versus, you know, previously it could go down to 50. And this way also there we have a running list of people who need follow-up calls, who have missed. You know, if I've got a downtime, I'll just pick up the phone and call somebody who's expecting the call. So that technology has certainly helped. The other technology that came into CAMH, which is new, it's still a bit glitchy, but when we are scheduling people or their follow-ups, it can send a text message to remind, like an appointment reminder by either text message or by phone. It's not always 100%, but it certainly does do that. And now I want to change to some of the challenges, or maybe before we do that, Sarah Kring has this question, I think, which is helpful, I think, for us to share in terms of how do you keep participants engaged virtually, and how do you keep the rates from week to week? So what are your participation rates? So Huma, I think this is a question for you. And
yeah, so we these days we tend to over-register for our group. So we'll purposely enroll more people than we know will show from you know, history. We know about 50% of who we register in the beginning will finish the group, especially the 6-week group. So we tend to go for more people because we know people will inevitably drop out. I think it comes down to really people's motivation to stay with group. And sometimes people have never done group, so they don't really even know if it's something that's helpful for them. So they might try a few sessions and think, you know what, this isn't for me. So it's hard to say. I mean, you know, with week to week, I don't think it's much different than it was when we did things in person, actually. I think it's about the same amount of showing rate compared to registration. In terms of how we keep people engaged virtually, I think it's people are just engaged when they're attending a group, when they're actively logging in to participate in these sessions, and they know that they're going to be sitting through a session for 90 minutes. I think they've kind of bought into the idea of it, and the people who don't find it's for them tend not to return. So I think it's kind of more of a participant side thing more than for us, but obviously we try to keep things interesting by changing up the topics and making sure we're going with what the participants actually want to speak about rather than what we had planned for the session. Sometimes, you know, we go off script and we don't use all the handouts that we have planned to make sure that people still are getting what they need out of the group.
And Colleen, from a patient perspective, and a client perspective, what do you find helpful that keeps you engaged and when you're doing this virtually, like, you know, like we're doing now? Oh, sorry, I'm going to have my favorite mug.
Is that better?
Oh, much better. Yeah.
Oh, okay. Well, I find the accountability going there every week and listening to Huma and Stephanie, and like they encourage you, like having to, you know, be real with where you're at with your smoking cessation or not, like whether you're still smoking, and the encouragement to, if you are smoking, to try to bring it down in amount, and ways to achieve this, and so there's always an element of hope, and there's with other participants in the online support. It's just really nice that it's all about smoking. It's not any other addiction. It's specifically about smoking.
Mm-hmm.
That's what's good about it.
And during the sessions, what allows you to stay more focused on the session rather than what's happening in your home or what around you? Is there anything that you do or that's helpful to keep you engaged in the conversation that's going on online?
Well, I just listen. I listen and listen to others is helpful.
Yeah.
I find it helpful to listen to others and where they're at.
Okay.
Mm-hmm.
That's great. So I think as part of that engagement, I think Marilyn asked the question is about, do you share slides during the thing, or do you keep it on this group, this gallery view like we have right now?
Yeah, so
what do you find helpful and working?
For the skills group, we have handouts that we used to have before as well. So now we email the handouts out in advance of the group, but we also share them during the group. And then for the ongoing group, the support group that we have, that's kind of the second stage of groups. That one we just share as needed. So for the most part, it is kind of like the view you're seeing now, the gallery view. But if something comes up, a topic comes up, and we have a handout that's relevant, or even going back to a handout from the skills session, we can bring it back into the group and share it at that point. So it just depends on which group we're doing, but we do share.
And what about chat? Do you allow the chat to happen on the side like we're doing right now, or is that do you hold off on chat?
Yeah, so for confidentiality and to kind of manage the group a little bit easier, we do turn off chatting for the participants. The only people they can chat with are the facilitators.
Okay. Yeah, so then that can keep some constraints around things happen. Otherwise, you have these parallel things happening in the side, and
That's right.
You can. So there are some rules around this that make it work. So that, and it sounds to me there's a lot of prep before orientation, and then making some rules during the session that can, because the difference between in-person is when somebody comes to an in-person group, they're in a context and you're together and you're not distracted by the phone ringing or or somebody knocking at the door or whatever, or the bag of chips lying on the kitchen counter table or whatever it might be. So that is an issue. And can you speak to some of the other rules like smoking during the session or things like that?
Yeah, absolutely. So we make it very clear to participants that obviously we ask them not to smoke in the session. We preface it as pretend you're actually in a room with us. So if you were in our group room, what would you be doing? How would you be behaving? What would you bring with you into that session? And we ask people to emulate that when they're in the virtual room with us. So obviously not having any paraphernalia for smoking, vaping, other substances, alcohol, anything like that visible on their camera. Attending group when they're not under the influence of other substances or alcohol. Making sure that there's not too much going on in their background, making sure that their cat's not jumping all over them. Obviously it happens. We can't prevent pets from wanting to sit on a nice warm laptop, but we ask people to be mindful of that. And if there is something going on, we ask them to turn off their camera, turn off their mic, do what they need to do, and then come back to group when they're ready to join us again.
Yeah, thank you. And again, in this, as a therapist, how are you feeling your connection or your therapeutic relationship is developing with the clients? Especially, Colleen is known to us, so Colleen from before, but for new clients, never met them before. How does that, what's different about it? What's good about it? What's not so good about it?
Yeah, so my first interaction with the clients is usually over the phone when I do their assessment. And it's actually kind of, it's interesting you asked that, Peter, because it's nice to see people in group once we've had conversations with them over the phone, and people will always comment, oh, it's so nice to actually see your face. So I think even that slight interaction kind of increases the rapport a little bit, because you've kind of gotten to know them a little bit, but you haven't seen their face. So it kind of reminds me of The Voice, the reality show The Voice, where you don't actually know anything about the client other than what they're showing you. So yeah, it's been an interesting kind of switch, but I think, at this point in the pandemic, I think we're so used to connecting this way that that awkwardness is kind of isn't as real anymore. It's not as at the forefront. So I think it just, you connect virtually, you kind of accept that this is how it's going to be, and you leave it as maybe one day we'll get to meet. So yeah, I think that's been my experience.
That's great. Now, and again, Chantal has this great question for Colleen, is that, when we do anything in person like groups, is people haven't arrived, they're waiting to go into the room, there's chit chat happening on the side, and and then there's chit chat happening after, or you leave together. When it's virtual, you start, suddenly you're beamed in and suddenly you're beamed out, right? There's no arrival or closures, and none of this informal connection. So Colleen, can you speak a little bit about that in terms of online versus in person, those informal sort of things? Oh, my mug is coming up again.
Well, I used to enjoy coming into the clinic, 15 minutes early and seeing other clients or group members arrive, and just kind of chatting with them a bit and getting caught up with them for the week, and seeing Natalie, the receptionist, and I did like that. It was a personal connection, but I think I miss that a little bit. I no longer miss it. I did miss that, but not anymore.
All right, so that's thanks for sharing that. Yes, that has been part of the trade-off, this abruptness of, and also you're doing things and you're suddenly into group, and so versus when you're coming to therapy in person, you have a bit of a build-up, you do it, then you have a time to process it because you're leaving and you're going back, whereas now you're in it and you're out of it and straight into your next activity, which is, we don't know what that effect is going to be, but that is one of the things to be in mind. And depending on your setup, maybe there are possibilities of arrival practices to get people more sort of grounded and in more present into the situation, and then a departure practice so that they feel and leave into another activity rather than an abrupt end, which means, because we'd have to become more mindful for that as we ending sessions. Even the phone call sessions often spend some time doing like an arrival practice, and then going into ending the session with not an abrupt, okay, sorry, gotta go, bang. It's about that. So those are some of the things as we go to virtual we have to pay attention to. Okay, so so people can use Zoom, and as long as it's a secure platform. We at CAMH have Webex, but many people have Teams. It doesn't matter, because if you're the host, you just have to send the link out to the client. And we use platforms in Ontario that have been vetted through and by the OTN, Ontario Telemedicine Network. So Webex is one of those platforms that the hospital had in possession, and so got it vetted, and so we use that. So Dr. Deb Saunders is telling us about their program went virtual over the pandemic. They use a hybrid program pre-pandemic, and they find out that they can fax the medication to the pharmacy, and patients are very receptive to this in the oncology setting. So that's great. So you can see some innovations that have happened. Fatima talked about individual phone and curbside NRT pickup. So you don't have people who can do all of this. So, and they have no tech or pay-as-you-go phone. So absolutely, for our clients, some of them, we see them and they come by and pick up NRT. During the Omicron, we were trying to reduce the number of people having to come down, because many of them have COPD, they have problems, and they're living in shelter, so you can't mail it to them. And so we would make arrangements for them to do a come by and pick up. And Darrelle, do you want to talk a little bit about that sort of flexibility?
Absolutely. That's one of the things that's been really interesting about the study. Like when we had to change everything over and we had to move to a virtual platform and virtual model, you do what you can with the technology that's available, and we provide a framework for obtaining virtual consent forms and things like that. But then we got these wonderful stories from our practitioners who are implementing the STOP study about their creative problem solving when it comes to providing their care for their clients. So like what has been said in the chat here, getting NRT to people, mailing it out, dropping it off, on-site pickup. One of my favorites is the drive-through pickup, literally out the window into someone's car. And even one practitioner who set up a pickup in a parking lot so people could drive by and get their NRT handed to them. She did have a small incident with the OPP while she was doing that. They were very curious about what she was doing, but everything worked out in the end and it was fine. And it just really shows the creativity that people have employed during the pandemic and their willingness to adapt and go the extra mile for clients to provide the care and support that they need. So that's been some really great feedback that we've had from our practitioners from the STOP program.
Yeah, and again, we thought STOP would come to a crashing halt, right? It'd come down to zero, but it didn't come down to zero. We took a big hit. It went down to 17,020 from 27,000. It went down to 17,000, but it didn't go down to zero. So great kudos to all the the creativity that all our STOP practitioners use to make sure that this critical thing. And we made no assumptions around patients, right? Everybody said, well, you should be worried about the pandemic. Well, one thing is that smoking makes you more at risk of having bad complications from COVID. So, but also, and many of our people who do smoke have comorbidities like COPD or other diabetes or other conditions that make it much harder for them not to. So we really commend that, we had these multiple ways in which we could balance. Now, some settings had to shut down because of redeployment, but which is why we started Stop on the Net. And I think I should just let you hand that over to you to talk about, our adaptation. So let me give that to you.
Yes, that's our big win during the pandemic has been Stop on the Net. So we introduced that in October of 2020, basically as an option for clients who could not enroll in the STOP program because their healthcare provider had shut down due to COVID. Stop on the Net is an entirely virtual program. From every step, from the consents, the intake of the data, the NRT mail out, the follow-up, everything is entirely online. So clients go to our website, they take a 20-minute enrollment survey to see if they qualify for this program. And what we offer through Stop on the Net is an 8-week kit of NRT, either high dose or low dose based on the client's smoking. And then it's mailed directly to their homes. So there are a couple more medical restrictions for this program just because we don't offer the healthcare provider oversight that the standard STOP program has. But really one of the main benefits is that people who don't have a healthcare provider that offers the standard STOP program, this program can be open to them. So it can actually have maybe a broader reach than our STOP program does because it's open to anyone in Ontario who qualifies and not just individuals who are rostered at the clinics that are offering STOP. So to date, Stop on the Net has enrolled over 15,000 people. And we are currently enrolling about 700 to 800 people per week. So that's pretty exciting for us. January was our biggest month so far. We had almost 4,000 people enroll. So it's kind of an exciting program. It's one of those things, it doesn't offer the breadth that the regular STOP program does, but it's kind of a good method of, there's a little bit of triage here. So clients who maybe don't have access to the clinic or maybe don't have as many comorbidities or don't have as great a need for counseling support, maybe Stop on the Net is a better option for them versus, maybe people who are smoking a great deal and really do need the extra support. The STOP program is still good for them and it's still available. So we now actually have these two great options to offer a broader range to clients.
Thanks. And also if they do come to Stop on the Net, there's the online CBT SelfHelp link that they can do. So maybe could you talk a little bit about that?
So we offer actually a lot of online support through the website. So there are the STOP program has always had a lot of great online options and self-help support options.
So what we do is we send out a link to these online options through our enrollment surveys, through the 10-week surveys, and also through the welcome package that we send out. So because we don't offer the healthcare provider support that the standard STOP program offers, we offer these online support systems that people can use themselves to help out when they do feel that they're struggling. Another option that we actually have recently launched is an app. So for people who have a smartphone, we have the My Change app, and that can be used in conjunction with something like Stop on the Net for people who are a little more, I want to do this myself, I want to track, and I want to, put this information on my phone so it's easily accessible. So that's another great tool that we option through the self-help options on the website.
Yeah. And all of that is free, right? So they can just, anybody can use that app. You don't have to be part of STOP. Anyone can download that app and use it on both Android and iPhone. And
yes,
what it does, and you can use it somebody can use it by themselves, or if you have a client, you can coach them through it. It's, if for those of you who've used My Change Plan workbook, it's exactly the workbook on this, and it actually provides that help in between sessions between you and what they have. And so if your clients are willing to do that, it really helps them keep track, reminders, and some evidence-based things like, for example, you can load that when people are having cravings, what they can do, and they can, make sure that it gives them in the moment ideas, and reminds them what they can do or what they've planned to do when they have a craving. So we're really trying to use technology in those ways to do that. We have about 10 minutes left, and there are lots of questions coming in. One of the things is the sessions, as we said, are about 90 minutes. The group sessions are about 90 minutes, but you need to at least prep before that it's about a half hour before, at least, if not more, and then obviously the notes that happen after that. So it can get pretty big, long, but the session itself is 90 minutes. Our pre-screening phone calls are essentially the STOP assessment and suicide risk assessment and consent to treatment, right? It's basically those. CAMH has a particular falls risk assessment, which is part of our standard, but the suicide risk assessment is also done. And if you're interested in a protocol, we have a protocol on managing suicide risk online, and that's being prepared for publication, but it's being used in STOP already. So if anybody needs that protocol, feel free to reach out to us. I'm just going to, so the arrival and departure practices, what do you think? I mean, what particular arrival or departure practices do you use in groups for your groups, Huma? And then I can talk about what I do individually.
Yeah, absolutely. So, for arrival, it's that 15-minute buffer. So people log in, some people will log in right at 4:45 if the group starts at 5. They'll log in right 15 minutes before, and then they have those 15 minutes to kind of, chill in front of the computer until we start the group. Some people are closer to that 5 o'clock. So that's kind of, we ask them the questions, we tell them to get settled, we tell them to grab, some water or coffee or whatever they need to be comfortable, go to the washroom. So that kind of prepares people. The departure, we do check out for our group. So in the last 10 or so minutes, depending on the size of the group, we ask clients, we kind of say we're coming to the end. Let's think about the next couple of weeks or the next week until we meet. What are some things we're going to work on during that time? And we kind of give people that opportunity to close out, any last comments, that kind of stuff. So it kind of brings everything to a close. We don't just kind of abruptly say, oh, it's time, we're done.
Yeah. Thanks. And yeah, individually it's similar. I mean, depending on on the person and how long you've known them, you could do a 2-minute breathing exercise. Okay, are you comfortable? Are you settled? After we do all of that, let's now become present together and talk about, okay, focus, and then start with an open-ended question to help stimulate a thoughtful response. And so that again helps ground people back into the moment, and the conversation is a lot more open-ended questions, because I think that helps people stay engaged a lot more. And then the closure practice is again a departure thing, like, okay, we're coming to the end, and here's what I reflect back what I've heard, and get them to listening for what commitments they're making from now till the next time they're seeing me. So my closing question is often an open-ended question as well, because then it helps consolidate what they need to do. So it's not, I want to see you in a week. It says from now till the next time, what are some of the things that you will notice, do, or change that'll help you get closer towards your goal. So that's one question, and I listen, or follow, or it can be, when would it be useful for you to follow up around the things that you said? And that causes, again, a grounding for the person to really reflect on what they want to, and what will be useful. So so you want to leave a few minutes at the end to be able to have that conversation, because then you've got that person present for that end of session too, as opposed to, thank you for coming, see you next week, bye, and you're gone. Another question is, can people outside of Ontario, you use the My Change Plan, it can be used anywhere in the world. There's no thing, it's just STOP. The STOP program is in Ontario only, but we've just had a great partnership with Lands in Nova Scotia, did a small pilot, which I think finished in a week.
Wow, less than a week, 5 days. It was amazing.
5 days.
We weren't sure how long it was going to run for, because they had a set number that people that they wanted to reach. It was so successful, they closed out within 5 days. It was fantastic.
5 days. So and we are open to working with other jurisdictions if they're wanting to try to use Stop on the Net to help them as well do this thing and pivot during pandemic. We were more than welcome. We've figured it out with Lands in Nova Scotia, and so Lung Association Nova Scotia. So if there's any other groups that want to try it out and make sure that your populations get it, as long as Canada Post works, and we can make this work. So Stop on the Net is kind of, if there's a provincial jurisdiction that wants to do it, we can certainly make it available. The question is about providing written quit plans that can be shared with other healthcare professionals like GPs. Do you mail them out to participants, or is the most communication done through email? So I don't know. I'll answer a bit of this, and Huma, please jump in. When we write a note in the chart, we can have a referral GP get a copy of it, and then that gets sent by fax or email, depending on what how that physician or healthcare provider has done it. But it is not consistently done. We were trying to do this in the past, but it's a lot of work, and we weren't even sure it was being read. We've been more selective. So, for example, we have patients undergoing chemotherapy or cancer, or they're on multiple psychiatric meds that need, and the person might have some change to their levels. Yes, we send it out, but not routinely, unless, Huma, you can correct me if you do something for groups.
No, that's absolutely correct. We kind of we leave it up to the clients to share that information with their GPs as well, if they're quitting smoking, to let them know, so that of course they can monitor. And then for us, I mean, in terms of the work we do for helping the clients create their own quit plans, it's client directed. So we don't have a template that we use. We individualize it to each client for what they need and encourage them to work on the things that they feel like they need to work on.
And I think John McFarlane has this great question about, NRT says keep it at room temperature, yes, and mailing it out through all the seasons, yes. We actually, in 2005, when we did the first mass distribution of NRT, we had to do that check, and we worked with the manufacturers to get what is the range of temperatures that it can experience before it gets, and they came back, and all Canadian temperatures pretty much, I think, unless you're getting to the Antarctic, you're pretty good that you can do this. So and again, if there are other questions, I know we're coming to the end. One final comment from Colleen. So Colleen, you get the final word. We will answer everybody's question, but Colleen to do that. So Colleen, what final question or advice would you have to all our listeners, or everybody who's joined the webinar today?
It's a tough call to quit smoking, and you need support, and it really helps. The more you get, the more it helps. And the CAMH staff, I think they're excellent, every one of them. They're very patient, and they're very informed, and it's wonderful that they provide the nicotine replacement and other medications. I think it's wonderful.
Thank you, Colleen. And I want to thank our other panelists as well, Huma and Darrelle, for your sharing your thoughts and wisdom. We wanted to keep this interactive. And for the questions we didn't get to, we will, sorry, Rosa's put in there that we will try to answer via listserv, so please join that. And hopefully we gave you a flavor of how technology is not the panacea, but certainly can enable a lot of things. And we are really blessed and fortunate to be living in a country like Canada where this is possible. And that we do have, you know, I know there's a lot of darkness around, but this is a good news story. And we are all here to help each other to make sure we get through this. So thank you everybody for your contributions and the work that you do. And thank you very much, and have a great afternoon. Thank you, Natalie.
Yes, thank you, everyone. I do have a few housekeeping slides before we go, but I know it's time, so if you need to go ahead, and we will be sending out all of the slides and the recording this afternoon. So I just wanted to say, sorry, let me get to my right slide. I just want to say thank you again to all of our panelists, so Peter, Huma, Darrelle, and Colleen. It was such an informative and relevant webinar, so thank you so much, and I can tell that everyone enjoyed and learned a lot. So again, just a little reminder that I will be sending out the evaluation and post-learning assessment by the end of tomorrow, and you'll have 1 week to complete that in order to receive a letter of completion. I also just wanted to let you all know about our next webinar coming up on March 9th on technology-enabled collaborative care for diabetes management, and registration for that will be opening soon. And if you happen to miss a portion of today's webinar or want to view it again or see another Teach webinar from the past, you can find our archive list on our website. For now, thank you all so much for coming and participating, and we hope you have a great rest of your day. Bye, everyone.
Bye.